Hello, this is going to be a brief presentation talking about DVTs and PEs for the sub-I. So VTE, or venous thromboembolism, is a broader category to talk about DVTs and pulmonary embolism. They are one and the same. It is a clot in a vessel. DVTs are often found in lower extremities but can be in upper extremities. DVTs can throw off clot to cause pulmonary embolism. Pulmonary embolisms can also throw off clots to make worse pulmonary embolisms, and the treatment is going to be similar. Risk factors for DVT are an important thing to know because these are going to be things you're asking about if you're worried about a DVT and or a pulmonary embolism. What we categorize things into is the Virchow's triad, where there are three big risk factors. One is venous stasis. Examples include being bedridden, being on a long flight for over 6 hours, or being post-op and kind of staying still. Second is endothelial trauma. Endothelial trauma, this is things like having a central line or some other type of trauma to the vessel. And third is having hypercoagulability. So patients with cancer have hypercoagulability. People with sepsis or also a coagulation disorder have this risk factor. And then these are broken down into odds ratios, where you see if a patient has a femur fracture, they have an odds ratio greater than 10 of having a DVT than a standard patient, whereas being on a plane for 6 hours increases your odds by a little more than 2. There is a great JAMA Rational Clinical Exam article entitled, "Does This Patient Have Pulmonary Embolism?" that goes into more details about some of these risk factors, but these are good to know. DVT prophylaxis is important because almost every patient on the hospital service will be on some type of DVT prophylaxis. Most often we use daily Lovenox injections. You can also use heparin. The calculation to determine if a patient needs to be on DVT prophylaxis and what type are two competing interests. One is looking at what their risk factors are of clotting versus if they have any bleeding contraindications. Someone with an acute GI bleed should not be getting any type of blood thinner. And then also balancing the pharmacological versus mechanical prophylaxis. If a patient cannot get a blood thinner, a pharmacological one, you have other options like mechanical prophylaxis, such as compression stockings, which are also shown to decrease DVTs but don't work quite as well. The diagnosis of a DVT, most common signs and symptoms include increase in leg circumference, pain and tenderness at the site, warmth and redness, and venous distension. You won't always have all of these. Sometimes these are tough to catch, but what we do use is a Wells score. That being said, a Wells score for DVT is not really helpful for inpatient. It's more of an outpatient setting. But ultimately, the diagnosis is going to be Doppler ultrasound, a very low invasive test that is easy to rule out DVTs. The diagnosis of a pulmonary embolism often present with dyspnea, shortness of breath, tachypnea, pleuritic chest pain or chest pain upon taking a big deep breath. You'll often have a little bit of hemoptysis, and hypoxia can be a presenting factor either on pulse ox or an ABG. In this setting, it is important to calculate a Wells score, which will help you risk stratify how likely a patient is to have a pulmonary embolism based on their signs, symptoms, and history. Things to check or order are an EKG, a chest x-ray, and a D-dimer. D-dimer is really only used to rule out a PE if you think there is a low likelihood. You can check out the YEAR study, which is a new study that kind of helps use the D-dimer to rule out PEs. And we'll talk about what to look for in an EKG and chest x-ray. Ultimately, a PE is diagnosed by a CT or a SCAT scan using a PE protocol, which does involve contrast, or if there is a contrast contraindication, a VQ scan can also be used. The EKG findings first, EKGs are often normal in the setting of a pulmonary embolism. The most common presentation is simply sinus tachycardia, which can be caused by a lot of things in sick patients. But the one thing you definitely want to be looking for on an EKG with suspected PE are signs of right heart strain. Saying, is there a clot that is causing strain on the right side of the heart? The major components to be looking for are T-wave inversions in the precordial leads, V1 to V4. If you see a right bundle branch block, or the common S1, Q3, T3, common in the boards and test questions, but less common in the actual awards. This is when you have an S in 1, a Q in 3, and T-wave inversions in 3, all of which are not super common. There is a good resource in the bottom right corner from Life in the Fast Lane about pulmonary embolisms and EKGs. That's worth checking out if you're interested. This is an EKG of a patient with a pulmonary embolism, and though the patient does not have sinus tachycardia, they do have other evidence of right heart strain that you can see in pulmonary embolism. First, you'll notice that there is a right axis deviation. There are T-wave inversions in the precordial leads, V1 through V4. There is also a right bundle branch block that you can see very well in the precordial leads. And also of note is this does have the S1, Q3, T3 findings of an S-wave in lead 1, a Q-wave in lead 3, and an inverted T-wave in Q3 as well. On CT scan, this is a good example of what you're looking at for a pulmonary embolism. You'll see the contrast coming out of the large vessel of the heart. That is the white contrast for blood. And then you'll see a darker spot where the contrast is no longer continuing. I'm going to circle it. This is a pulmonary embolism. When assessing for right heart strain, we talked about on the EKG, looking for right bundle branch block, T-wave inversions, and S1, Q3, T3. There's other ways to look for right heart strain, and that's on an echo. You can see right ventricular hypokinesis. Sometimes you'll get some tricuspid regurgitation or elevated right ventricular systolic pressure. You can also look for what's called a McConnell sign. This is hypokinesis at the right ventricle wall, but normal at the apex. On a CT, you might see right ventricular enlargement. And then with labs, you can see an elevated proBNP and elevated troponin showing, again, signs of strain on the heart. With some of these findings, you can actually then calculate morbidity estimates using the Simplified Pulmonary Embolism Severity Index. The reason it's important to determine if there's right heart strain is that that is going to help with risk classification of pulmonary embolism. We classify pulmonary embolism into 3 risk categories: low risk, moderate risk, or what we call submassive, and high risk, which are massive. These are associated with very different mortality rates. A low risk PE is one that does not have any evidence of right heart strain. The patient is having normal vital signs. This can actually be treated as an outpatient. A submassive PE does have evidence of right heart strain, whether it's a troponin leak or right heart strain on EKG and echo. These patients are a little more worrisome because they can turn into high risk or massive PEs. So these patients are usually admitted to the hospital for monitoring. Finally, high risk or massive PEs are worrisome. They have an evidence of right heart strain and also have hemodynamic instability with hypotension. These are often requiring systemic or catheter-directed thrombolysis or surgical thrombectomy, thrombus removal. These are very sick patients. Of note, you'll see that these risk classifications, size is not one of the important factors, whether it's a saddle embolus versus a very small embolus. It's really how it affects the body. Is there right heart strain? Is there changes in hemodynamics? The only slight exception to point out is that low risk subsegmental PEs actually don't necessarily need treatment. Based on guidelines now, they can be just observed rather than treated. There is a link at the bottom that has some good reading for PEs that might be worthwhile if you want to learn more. Now, there are a lot of anticoagulation options in the treatment and prevention of VTE. I think for medical students, this can sometimes be overwhelming, so we're going to try to break it down one by one. First and most common is heparin. It is often given as a heparin drip in the hospital. That's because it's easy to start and stop. So if a patient needs to go for a procedure, you can stop the anticoagulation whenever you want to. It is important to note that though it's rare, this can cause heparin-induced thrombocytopenia. This is monitored by PTT draws that nursing usually does on their own protocol. Second, a very common anticoagulation treatment that we use is Lovenox. This can be used for DVT prophylaxis, as we discussed, or it's actually the first-line treatment for PE in cancer patients or in patients with recurrent PEs and VTEs. It can be contraindicated in advanced chronic kidney disease, but this is a good injection treatment for clots. Warfarin is one of the oldest treatments. It is an oral medicine monitored by INR. It's influenced by diet and other medical interactions. It's a second-line therapy in patients without cancer. You'll see a lot of patients on warfarin and having to go to warfarin clinic or INR clinic to have their INRs maintained. And now the new medicines that are not even that new anymore are called the DOACs. This is things like apixaban or Eliquis and rivaroxaban and Pradaxa. This is the new first-line therapy in patients without cancer. They had studies that showed they were non-inferior to warfarin. Sometimes they do need renal dose adjustment depending on the medicine and the chronic kidney disease stage. And recently now they've actually been shown to be non-inferior in cancer patients, so they may become first-line in cancer patients in the near future. But this is an oral medicine that does not require the same level of monitoring as warfarin and is not an injection like Lovenox, so these are gaining a lot of popularity. Fondaparinux is another sub-Q medicine. It's kind of similar to Lovenox. We really don't use it unless a patient cannot tolerate other options. And then finally, TPA is the IV medicine used for thrombolysis if a patient has massive PE. There is some new evidence that in high-risk submassive PE or certain cases of submassive PE, it might actually be beneficial as systemic therapy or as catheter-directed thrombolysis. But this is really something that you would only be doing in an ICU setting. Treatment duration is a bit of a moving target. Usually a provoked DVT or PE is treated with 3 to 6 months of anticoagulation if the provoking agent can be removed. So if a patient was on a birth control or had a PICC line and had a clot at the side of a PICC line, you would treat for 3 to 6 months, and that would be the end of it. If it was unprovoked or a otherwise other concerning clot, a lot of times we just discuss the risks and benefits with the hematology consult. If there is 2 unprovoked clots, we almost always treat with lifelong anticoagulation. An IVC filter is something else that might come up on rounds. This is really only indicated in patients with a clot if they have contraindications to pharmacological anticoagulation. So an IVC filter is a mechanical filter that is placed in the IVC, in the inferior vena cava, and meant to protect the lungs from having a clot go up and block your lung pathway. IVC filters have shown essentially decrease in some PE-related mortality, but does increase the amount of recurrent clots. It can also maybe help prevent PEs when the DVT is present, but does lead to recurrent clots and does not necessarily reduce recurrent PEs. So there's not a lot of enthusiasm when putting in IVC filters, and when we do put them in, it's usually as a bridge until they can be removed and then started on pharmacological anticoagulation. Other indications for anticoagulations that are just mentioned, they're outside the scope of this, but just in case you see a patient on warfarin or something and want to know why are they on it. Patients with atrial fibrillation have a higher risk of clots, so you calculate a CHADS-2 score and a Hasbled score that helps guide the decision making if they should be on anticoagulation. Also, patients with mechanical heart valves often need to be on anticoagulation. Some heart valves need to be bridged with heparin or Lovenox to warfarin. But just so you know that these medications are also used for other indications. All right, if you have any questions, please feel free to email me at jburke7@jhmi.edu. If there's any feedback, what was good, what was bad, what was missed, if you felt there was any egregious errors, please let me know. I'm happy to try to make these better if there is a way to make them more helpful. And for further reading, there is a link to the Thoracic Society's reading list for pulmonary embolism with a lot of top canonical trials and articles, some that are referenced in this presentation. Thanks.